An abdominal aortic aneurysm is any aorta that measures greater than 3 centimeters in diameter, which correlates to 150% its normal diameter. It is important to note that 90% of these will occur distal to the renal arteries. The surgical criteria for AAAs include an aorta greater than 5.5 centimeters, a rapidly expanding aorta, and any AAA that is symptomatic, suggesting rupture. AAAs are often asymptomatic until they rupture. When they do rupture, they may cause flank, back, or abdominal pain, which is often vague in nature. Some are associated with no pain, and the only presenting symptoms may be hypotension, weakness, dizziness, or syncope. Additionally, patients with ruptured AAAs may present in cardiac arrest. Physical exam is highly unreliable in the detection of AAAs. AAAs must be diagnosed rapidly and treated as a true surgical emergency, as they are associated with high mortality rates. Survival rates have been shown to decrease at a rate of 1% per minute. Additionally, the risk of rupture is proportional to the aorta's diameter, with aneurysms greater than 7 centimeters having up to a 50% risk of rupture per year. The first reported AAA detected by an emergency physician using ultrasound was in 1989. Because ultrasound can rapidly detect a AAA at the bedside of an unstable patient, it has since become essential in screening patients with suspected ruptured AAAs. Bedside ultrasound has been shown to have both excellent sensitivity and specificity in detecting AAAs. However, it must be noted that bedside ultrasound is not sufficient to rule out a ruptured AAA. When ultrasounding the abdominal aorta, it is important to keep in mind its basic anatomy. The abdominal aorta is entirely retroperitoneal. It enters the abdomen at T12 and bifurcates to the common iliacs at L2, which is typically the level of the umbilicus. As the aorta travels distally, it tapers and becomes more superficial, following the curvature of the lumbar spine. Because approximately 90% of abdominal Because approximately 90% of abdominal aortic aneurysms occur below the level of the renal arteries, it is important to recognize the branches of the abdominal aorta. The first branch off the abdominal aorta is the celiac artery. This comes off anteriorly and splits into the common hepatic and splenic arteries. This branching of the celiac artery is often referred to as the seagull sign. The next branch is the superior mesenteric artery, which also comes off anteriorly and runs anterior to the aorta as it travels distally. This branch is important to visualize because the renal arteries, which take off laterally just distal to the SMA, are not typically able to be visualized using ultrasound. Finally, the aorta ends as it splits into the common iliacs. When scanning the abdominal aorta, the low-frequency curvilinear probe is preferred. However, if unavailable, a phased array probe may also be adequate. The aorta should be scanned in both transverse and longitudinal planes, and should be visualized from the diaphragmatic hiatus to the bifurcation of the iliacs, with particular attention paid to the region distal to the SMA. Measurements should be taken at 3 distinct levels in the transverse plane. All measurements should be of the maximal diameter of the aorta from outer wall to outer wall. In order to obtain a transverse image of the abdominal aorta, start at the epigastrum with the probe indicator pointing to the patient's right. By starting here, the liver edge can be used as a sonographic window to improve imaging of the aorta. Here we can see the typical image obtained when scanning at the level of the epigastrum. The most important step in identifying the aorta is to first identify the vertebral body. This serves as the anchor of your image in the transverse plane. The vertebral body is hyperechoic and casts a posterior shadow. Its sonographic appearance is referred to as the horseshoe sign. Once this is identified, the IVC, as well as the aorta, which is round and located just to the left of midline, can be found anterior to the vertebral body. Once the aorta is identified, it should be imaged through its entirety from the takeoff of the celiac artery until it bifurcates into the common iliac arteries. Once again, the branches off the aorta help to identify which level of the aorta is currently being imaged. High in the abdomen is the sonographic seagull sign, where the celiac artery branches off the aorta anteriorly and splits into the hepatic and splenic arteries. At this level, we can see that the liver edge provides an excellent sonographic window to aid imaging and identification of the abdominal vasculature. In the mid-aorta, the SMA takes off anteriorly and courses just anterior to the aorta as it travels distally towards the bifurcation of the iliacs. Visualizing the aorta below the level of the SMA's branch point is important, as this is the most likely region for aortic aneurysms to develop. The aorta should then be imaged distally until the aorta splits into the common iliacs. Once again, measurements of the transverse aorta should be made at 3 distinct levels: proximally, mid, below the level of the SMA, and distal, just before the aorta bifurcates into the iliacs. Next, the aorta should be imaged in its longitudinal plane. Start in the transverse plane at the epigastrum and center the aorta into the middle of the screen. From here, slowly rotate the probe 90 degrees clockwise until the probe marker is pointing towards the patient's head. Care must be taken to visualize the aorta in the middle of the screen. The aorta should be visualized from the celiac artery to the bifurcation. Here is an image of the aorta in longitudinal. In this image, the proximal aorta is on the left of the screen, where we can see the takeoff of the celiac trunk and then the SMA. The most important aspect of imaging the aorta longitudinally is being able to distinguish it from the IVC. The IVC is found to the patient's right, enters the abdomen superiorly, and is thin-walled. Additionally, it does not have any anterior branches caudal to the hepatic veins, whereas the celiac and SMA can be visualized branching anteriorly off the aorta. IVC size also has respiratory variation. Pulsations alone are not adequate in distinguishing the IVC from the aorta. In contrast, the IVC has no anterior branches after the hepatic veins and is thin-walled and demonstrates respiratory variation. It may also be seen emptying into the right atrium. When the IVC is filled and plethoric, it can be particularly difficult to differentiate from the aorta. However, we can see again that there are no anterior branches caudal to the hepatic veins and that there is significant respiratory variation. Here we can see the transition from the inferiorly entering thick-walled aorta to the IVC, which is thin-walled and enters high in the abdomen. Note that aorta dives posteriorly behind the heart, while IVC enters directly into RA. It is useful to frequently rotate the probe while visualizing the aorta and IVC to ensure correct vessel orientation. Now let's look at some examples of abnormal abdominal aortas. This is a large abdominal aortic aneurysm measuring over 10 centimeters. Even in this large aneurysm, we can see how only measuring the intraluminal diameter of the aorta would greatly underestimate its true size. In this more subtle example, the intraluminal diameter is less than 3 centimeters and highlights the importance of always measuring from outer wall to outer wall. When in doubt, it's always safer to overestimate the aorta's diameter. This is another example of a large AAA. When imaged longitudinally, we can see a typical fusiform aneurysm involving the entire length of the abdominal aorta. On the other hand, there are smaller saccular aneurysms that may only involve a very small portion of the aorta. If the aorta is not carefully scanned in its entirety, these saccular aneurysms may be missed. Additionally, distal aneurysms that occur just before or involving the bifurcation into the iliacs can also be missed. Ultrasound of the abdominal aorta may also detect a dissection. An intimal flap with clot may be visualized. However, ultrasound is less sensitive for dissection and should not be ruled out without additional imaging, such as a CAT scan. Because the transverse colon overlies the mid-aorta, bile gas often obscures adequate imaging of the aorta. To help improve visualization, graded compression may be used by applying slow incremental pressure with the probe to displace bile gas from beneath the probe. It may also be helpful to move the probe to either side of midline, avoiding bile gas altogether. Another common cause of poor visualization is the obese patient. In these cases, firm pressure should be applied to compress the soft tissues. Placing the patient in left lateral decubitus position to displace the pannus off of the midline may also improve visualization of the aorta. There are many pitfalls to avoid when performing an ultrasound of the abdominal aorta. Improper measurements of the aortic diameter, specifically underestimating the aortic diameter, should be avoided by always measuring from outer wall to outer wall. Mistaking the IVC for the aorta can be prevented by assuring that the probe indicator is to the patient's right and visualizing the aorta as you rotate from transverse to longitudinal views. By always scanning the full length of the aorta from the celiac artery down to the bifurcation of the iliacs, saccular and infrarenal aneurysms will not be missed. Another common mistake is not having adequate depth. This may cause the sonographer to mistake the SMA for the aorta. To prevent this, first identify the vertebral body before attempting to find the aorta. Because most ruptured aneurysms bleed into the retroperitoneal space, the FAST exam is not sufficient to rule out a ruptured aneurysm. Finally, the sonographer must realize that bedside ultrasound may be limited. When ultrasound is inconclusive, alternative imaging modalities, such as CAT scan of the abdomen, should be utilized. This concludes our discussion on ultrasound of the abdominal aorta. These are my references. Thank you for your attention. I'd also like to thank Dr. Fields, Dean, Herbst, Leteplo, and Lewis for their contributions.